This is an educational program promoting successful rehabilitation outcomes in multiple sclerosis. This 6-part module series will describe the role of physical therapy for rehabilitation and management of symptoms related to multiple sclerosis. This educational program has been developed in conjunction with the Consortium of Multiple Sclerosis Centers and is supported through an educational grant from Accorda Therapeutics. This educational program is designed to enhance the knowledge of rehabilitation professionals working with people with multiple sclerosis. The educational program will help you recognize the unique rehabilitative needs of people with MS, describe and demonstrate specific evaluation techniques and standardized measures, as well as describe and demonstrate treatment techniques to enhance the function recovery and, when appropriate, neuroplasticity. This educational program will provide you with long-term management skills for patients who have varying needs and disability level. Multiple sclerosis differs from other conditions requiring rehabilitation in that the disease itself is progressive, often having a relapsing and remitting course. The nature of the disability is also dynamic in that it can change from week to week or even day to day. The good news is that there is emerging evidence for neuroplasticity in multiple sclerosis, and from a management perspective, we need to make accommodations for our patients related to the fatigue they experience, heat-related effects on their symptoms, spasticity, and cognitive dysfunction. Multiple sclerosis is an autoimmune disease affecting the central nervous system. The primary targets are the brain, the spinal cord, and the optic nerves. What we know happens in multiple sclerosis is that the myelin which coats the nerves becomes inflamed and scarred. We also now recognize that the nerve fibers themselves, the axons, undergo degeneration. As a result of this demyelination as well as degeneration, the scarring that is evident in multiple sclerosis is the result of inflammatory attacks which occur at multiple sites throughout the central nervous system. Immune cells, or T cells, are recruited from the bone marrow into the bloodstream where they become activated. These activated T cells cross through the blood-brain barrier and launch an attack on the myelin and nerve fibers. As seen in this graphic, the T cells cause the demyelination and axonal degeneration on the nerve fiber, distorting the propagation of action potentials. Multiple sclerosis has different patterns of progression. The most common is the relapsing remitting, where an individual has an occurrence of symptoms which may last from days to weeks, and then they suddenly subside. Another type of pattern of multiple sclerosis is secondary progressive, and this is most often seen after the individual has had relapsing remitting MS for over 10 years duration. By far, the majority of individuals with MS have relapsing remitting MS, and only a small percentage, 5 to 10%, develop what is referred to as primary progressive MS. In primary progressive or progressive relapsing, the individual never really has a period of time when the disease process slows down or stops. It is a slow progression over time, resulting in further and further disability. This next slide shows us 3 different stages of multiple sclerosis represented by the MRIs on the top of the slide. On the bottom of the slide is a corresponding graphic which demonstrates the patient's activity in MRI represented by the arrows ascending, and yet the patient is in a preclinical stage, meaning that they've not had an exacerbation or initial onset of the disease. Notice as we move into the relapsing stage, there has been a deflection of the relapse and impairment bar, showing that the patient has now had an attack of multiple sclerosis, their first attack, And note the increase in MRI activity reflected by the number of arrows showing at the bottom of the graphic. Even when the patient goes into remission, as demonstrated by the relapse and impairment bar going back to baseline, those arrows are still very active, showing that disease progression continues even though the patient is without symptoms. That relapsing stage could be indicated by the MRI-B, where we start to see enlargement of the ventricles and we start to see more white matter lesions developing throughout the cerebral hemispheres. As mentioned previously, most patients with relapsing remitting multiple sclerosis move into what's referred to as secondary progressive MS, and this is typically after 10 years of age of the disease process. In secondary progressive MS, take note of the diminishing red bar dropping down towards the bottom line, showing that brain volume is now deteriorating. So there is significant cerebral atrophy as we move into secondary progressive. The actual MRI activity has slowed down. We don't see as much MRI activity, again noted by those arrows at the bottom of the graphic, and yet the progression of the disease continues with greater disability. This would be a typical progression of a patient with multiple sclerosis. The symptoms that we see in multiple sclerosis are unpredictable and vary among each individual. We commonly do observe muscle weakness and spasticity. Many of our patients will display balance and coordination problems. Fatigue is by far the #1 symptom that patients will complain when they have multiple sclerosis. Bladder and bowel dysfunction can occur. Cognitive difficulties are often unrecognized but present throughout the duration of the disease. Depression can certainly occur, and paresthesias, or numbness and tingling, can occur throughout all extremities. It's also not unusual for a patient to develop optic neuritis, loss of vision, or to have spontaneous nystagmus, which prevents them from clearly focusing on a target. Neuropathic pain can occur, as well as sexual dysfunction. The symptoms of multiple sclerosis are chronic and ongoing indicators of the lesions and the damage which occurs in the brain and/or the spinal cord. A relapse denotes a sudden flare-up or attack of symptoms that suddenly become increased, or potentially an onset of new symptoms. To confirm that in fact a relapse has occurred, the new symptoms or the intensity of symptoms should typically last several days to several weeks. This is an important point to note because many patients who develop infection, such as a urinary tract infection or an upper respiratory infection, will also experience an increase in their symptoms, which may mimic a relapse, but in fact does not need to be medically managed. The immune system's response to that new infection obviously can intensify the current symptoms that are present with multiple sclerosis. So this is important for rehabilitation therapists to recognize. When the patient presents with an increasing presentation of symptoms, the first thing is to discuss with them if there's a possibility that they have a UTI, an infection somewhere else in their body, or even some type of painful source of inflammation, such as decubiti. These particular problems will manifest the symptoms of MS, but do not mean that the disease is in fact exacerbating. The medical management of relapses typically involves intravenous or oral steroids. Management of the disease itself is used with medications that are referred to as interferons or Copaxone. We also have medications that can manage the symptoms that are evident with multiple sclerosis. Additional comprehensive management should include psychosocial support, and of course the focus of this educational program is to talk about the role of rehabilitation to maintain and improve function. Let's talk briefly about those disease-modifying therapies, and these are approved for relapsing remitting multiple sclerosis. All of the frontline medications discussed right here are injection medications. So we have different types of interferons, Avonex and Rebif, and we also have an interferon that's referred to as beta-1b, and that includes beta-seron and Extavia. Another injectable medication that is not an interferon is bladimir acetate, or Copaxone. These injection medications all differ in the frequency of the injection as well as whether they're intramuscular, which is Avonex, or subcutaneous. Another frontline medication used for relapsing remitting MS is infusion therapy. The patients now would go to an infusion center, and through an IV they would receive Tysabri or Novantrone. These are most often administered once a month. Newest on the market is an oral medication, Gilenya, which is also used to modify the disease progression of multiple sclerosis. Many patients who are on injection therapies are opting to switch to Gilenya to manage the disease progression. We also have medications that are predominantly for symptom management. Delfampridine, or Ampyra, is the latest on the market, and it works to truly enhance the propagation of action potentials along these demyelinated nerves. Intrathecal baclofen has been used as an antispasmodic to calm down the abnormal firing or spasticity in muscles that can result from the demyelination. Intrathecal baclofen includes a pump which is implanted and a catheter which is fed through the subdural space with the medication released right into the cerebrospinal fluid. Modafinil or Provigil, as well as amantadine or Symetrol, and Ritalin are all various stimulants used to treat the fatigue aspect of multiple sclerosis. Common MS impairments which impact function, which obviously as physical therapists we're most primarily concerned with, include weakness, that's spasticity, balance and coordination deficits, as well as sensory and perceptual deficits. Evaluating the levels of functional impairment is most often based upon the Expanded Disability Status Scale, or EDSS. A patient who is mildly involved with multiple sclerosis will have an EDSS score which may range from a 3 to a 5.5. A 0 would denote that the patient is truly symptom-free. As the disease progresses, the patient has more difficulty with ambulation, and therefore the EDSS score would be from 6.0 to 8.0. When an individual has become non-ambulatory as a result of disease progression, the EDSS is 8.5 and above. This is a nice graphic demonstrating the EDSS, showing the progressive nature of the disease and, unfortunately, the progressive nature of disability which our patients will display. As I noted previously, a 0 on the EDSS would mean that the patient has a normal neurologic exam and is not presenting with any symptoms at all. Once we get to the 3.0, we start to say that they have moderate disability in that they may be developing paresthesias, they might have a mild impact on their balance or coordination, but are still able to ambulate in the community without limitation. As they progress into 4.0 and then 5.0, we see that there's limitation to their ability to complete a full daily activity or, in fact, work a full-time job. 6.0 is when we see the progression to needing a unilateral device for ambulation. A 6.5 would mean they need a bilateral device, such as 2 straight canes or a walker. And then you can see from the representation, 7.0 would be wheelchair and 8.0 would be restricted to bed or chair. Let's take a look at 3 different patients. Our first patient displays an EDSS of 3 to 4, so we would certainly characterize her as being higher functioning with her multiple sclerosis. She's able to roll side to side without difficulty. Moving from sit to supine is a little bit more of a challenge. That might be weak trunk musculature from the MS, or it might be some orthopedic problems. Her sitting posture looks great. Upright posture, no need to hang on for assistance. As we watch her move over to the stairs, we'll start to see a suggestion of potentially some musculoskeletal changes in both hips and knees, which might be impacting her gait more. She's able to ascend and descend the stairs with the use of 2 handrails, and uses a reciprocal gait pattern. The therapist is guarding her, but she is certainly safe and independent in this task. So really, watching her walk now, we don't see any significant neurologic deficits to this patient's ambulation. In fact, you would say that maybe her primary limitation is in the lower extremities with hip, knee, and ankle changes, certainly genu valgus there. Our next patient has multiple sclerosis as well, and his EDSS now is going to be a 6.0 as he is using a single unilateral device on one side. He displays more of a hemiplegic type gait. We'll see that even more so now that the device has been removed. The therapist is guarding him much more closely. We see hip hiking, circumduction, no arm swing on that left, and then a sudden loss of balance. So though this patient had multiple sclerosis, he almost looks like a patient with a stroke. Our last patient is an EDSS of 8.0, meaning that she is non-ambulatory, utilizing her wheelchair for all of her mobility. You see her nicely doing weight shifting activities here in a prone on elbows position, and even doing unilateral reaching, which is obviously a very good exercise for the upper body. When she moves from prone on elbows into quadruped, you'll see that she needs the assistance of two therapists, one controlling her hip and pelvis and the other assisting with her shoulder girdle to get up into the quadruped position. Once in quadruped, she's again able to repeat that weight shifting, which is certainly encouraging the stability of the shoulder girdle musculature as well as the hip and pelvis musculature. Yet this same patient who is non-ambulatory and uses a wheelchair for mobility is able to stand and weight bear and do weight shifting activities in the parallel bars while she engages in the WE activity. As in all aspects of rehabilitative care, it is important to utilize standardized measures. In multiple sclerosis, the most commonly used standardized measure is the MS Functional Composite, or the MS-FC. That is comprised of 3 different measurements: the timed 25-foot walk, the 9-hole peg test, and the Paced Auditory Serial Addition Test, or PASAT. During this video, we will demonstrate the timed 25-foot walk, as all individuals in rehabilitation, specifically physical therapy, should utilize this standardized measure. We've already talked about the Expanded Disability Status Scale. A neurologist would most often fill out the EDSS. Other standardized scales include the Modified Fatigue Impact Scale, the Modified Ashworth Spasticity Scale, which again we'll describe in more detail, as that would be the role of the physical therapist to complete, and then the Multiple Sclerosis Neuropsychological Screening Questionnaire, which is most often completed by a neuropsychologist. The standardized gait measures that are recommended by the consortium of MS centers include not only the timed 25-foot walk, but also the timed up and go, the dynamic gait index, the 2-minute walk and the 6-minute walk test, as well as a self-report measure called the MS 12-item walking scale, which the patient completes on their own and reflects their perception of their ability to ambulate not only at home but in the community. During these 5 additional modules, we will see all of these gait measures demonstrated. Obviously, again, with any patient, it's important that we set goals, and from our goals, we develop the treatment plan to help the patient achieve an improvement in their overall functional mobility. We have to take note that patients with multiple sclerosis have unique needs. As we've mentioned, they have a progressive nature of the disease, which certainly is chronic. There is variability and unpredictability of their symptoms, sometimes triggered by infection, which we have to be sensitive to. And then there are these hidden or invisible symptoms, such as fatigue, cognitive changes, the presence of dysthesias or paresthesias, their bladder and bowel dysfunction, as well as depression or other mood issues. Another factor that we must take into consideration is heat sensitivity. Even in the Northeast, where our consortium of MS centers is located, we still have problems during the summer weather with humidity and heat impacting many patients who have multiple sclerosis. Again, the increase in temperature can make it appear as if the patient is having an exacerbation of their disease, when in fact it is simply the heating of the core body temperature that intensifies the presence of the symptoms. Again, in setting goals and developing the treatment plan, the patient and therapist must work together to identify the goals and priorities for the patient to achieve. It is important for the OT and the PT to be critical in helping the patients identify realistic and attainable goals while also sustaining their self-esteem and hope. As with all of our patients, our goals must be attainable, measurable, realistic, and as often as possible, functionally focused. The treatment plan then should be established to achieve the goals for the patient and as well include exercises and activities that are enjoyable, varied, and task-specific. Resources should be considered for home and community-based programs, and whenever possible, endurance or aerobic conditioning should be included into the exercise program. Important, as previously noted, to provide hope, support, and motivation, as these are key factors in ensuring the patient's compliance. Rehabilitation in MS establishes a lifelong relationship with the individual living with MS, with our focus on maintaining life roles with short-term rehabilitation as needed, promoting active exercise for health and wellness, and empowering the individuals to manage symptoms that impact on function. In this next module, we'll talk specifically about spasticity and weakness in MS, how we evaluate, as well as how we treat these particular impairments.